Thank you. I'm going to share my screen. While I do that, I think the three presenters and our special assistant, Sarah Wendells, are going to introduce ourselves. Sarah has been awesome in the chat, and you'll notice that she drops information and links, answers questions in the chat. And so I will quickly go first. I'm Nick Rademacher. I am an emergency physician at Trinity Grand Rapids in Grand Rapids. I'm also a technical assistant with the Michigan Opioid Partnership, and I'm happy to be here today. Our quick intro item today is we're gonna just talk briefly about our first experience with buprenorphine as a provider. And, this was 2018. I think I ordered the buprenorphine for the first time after getting my X-waiver, and I got a call from the pharmacist immediately. This is in the middle of the night, and said, "Oh, you can't prescribe this medication." And so a lot of what we're going to be talking about today is barriers and how to overcome those barriers to install a program. But I got kind of pushed back immediately. Eventually, they allowed me to do it that same day, but it was a phone call that I think would be kind of unsettling for many. The second time I ordered it, after an hour, the patient hadn't received it, and I realized that it was because buprenorphine wasn't in the emergency department. The nurse was busy with a septic patient, and the nurse had to leave the ED floor to go to the pharmacy to get the medication. And so this has kind of been a recurring theme for many of you that we've talked to, and for ourselves, is that when you're first starting, it can be intimidating. You can have some barriers, and we're going to help you through those today. Sarah Wendells, do you want to go next?
Absolutely. I am Sarah Wendells. I am not in Michigan right now. I'm based in Oakland, California. I am a co-founder of the California Bridge program, and really excited to be here with you today. A lot of the work that I'm doing now actually is bringing all of the lessons learned that we've developed over the last 4 or 5 years working in California with hundreds of hospitals, making sure that you and anybody else outside of California has all of that knowledge base so that you don't have to reinvent the wheel. I was a crucial component of all of the materials that you'll see today, and the ones that we shared at the previous training and on our website. And so I'm a great person that can share resources, and not just through California Bridge, but anything else nationally. So if there's any question, feel free to reach out or put in the chat, or if you're looking for anything in particular, I might be able to find something pretty quickly for you. So I'm thrilled to be here and support all of these great trainings, and I'll pass it off to Ariana.
Thank you, Sarah. So I am Ariana Campbell. I'm a PA. I work in a rural emergency department in Northern California. I'm also one of the co-founders and co-principal investigators of California Bridge, and really excited to be working with you all in Michigan here. My first patient that I treated with buprenorphine was in 2017, and I have to say, when I started, I started giving buprenorphine kind of as an early adopter. So California Bridge did not exist, and there was no resources. And I read a couple of articles. I gave my first dose, and I had been told that this isn't for a rural hospital. And of course I thought, why not? So when I first ordered it and it was being given, it's called an induction, right? I actually only call it a start now because I thought that was a barrier, but we called it an induction. My first patient was 24 weeks pregnant, and it was on Labor Day weekend. It was the Friday of Labor Day weekend. I didn't have my X-waiver quite yet. I had applied for it, but it hadn't come in the mail. So I felt like I was a little outside. I ordered it because it was the right thing to do. I had a 24-week pregnant woman in withdrawal, but after ordering it and it was about to be administered, I realized I was the first in the hospital to order this, and that they said it shouldn't be done, not that it shouldn't be, but it hadn't been done in many rural hospitals. And we called it an induction, and my patient was pregnant. So I sat there literally staring at her awkwardly, like, I'm inducing a 24-week pregnant patient. What does this all mean? And of course I gave it to her, and she was annoyed by me. And she ultimately got better. So in about 30 minutes, I just witnessed her start feeling better. And then she actually felt really good, and I discharged her. Well, since I didn't have my X-waiver yet, and because you can give it every day for 3 days, I ended up seeing her back every day, and she kept telling me how I wasn't giving her enough. So the very last day, she said, "You finally gave me enough." And giving her enough was like, I think I had given her 24 milligrams. But it was just really interesting because I sat there staring at my patient for 3 days in a row because I worked the whole weekend, and she taught me a lot. And then she also taught me that I shouldn't call it an induction because it felt really awkward. So and ultimately she ended up doing really great. And so yeah, that was my first patient. So, all right, Andy, I'm going to turn it over to you. You can talk about your first patient.
Yeah, you started on like a a special population patient. That's awesome. I think I failed the first time. Is I gave it, and the person swallowed it because we only have tablets. And so I remember going back and saying, "How are you feeling?" "Not better, man." Like, I don't know what that was. And then it was a reminder that you have to work with everybody involved, including the nurses and the patients, about how to take the medication, because it's not going to work if you swallow it. You get like a really low bioavailability. And so that was really fun and embarrassing. My name is Andy King, and I work at the DMC and here at Wayne State as an emergency physician and medical toxicologist. And it's great to be here and always fun to present with my two favorite people, Ariana and Nick. So I'm gonna turn it over. Nick, you're the first guy, right? You getting it going?
Yep, I'm going first today. So we already did our first item, and then we're gonna briefly kind of sample where everyone's at, and I'm gonna talk about some common barriers. Then Andy is going to discuss what needs to be done today to move you toward a functioning program. And then Ariana, around 11:55, is going to talk about ways to optimize the program for long-term success. So we're hopeful that when you leave here today, you'll have some confidence that you can build your program, that you'll have some tools to identify and recommend a clinical champion, assess and set up a network of community partners, evaluate and develop partners within the hospital, and design a program that is clinician friendly. So before I start, a quick reminder that yesterday, the Michigan Opioid Partnership sent out a worksheet that may help facilitate this discussion for everyone. Just some bullet points about current barriers, things you've experienced, where to go next. The most important bullet point in this worksheet is what is the one action item you intend to do after leaving today. I think I've learned that from different leadership conferences in the past, that every time you go to a lecture or a conference, if you leave with a goal that you actually complete just one, that you will slowly make progress. So just try to find one thing today that you think you can change and move you towards the right direction. Okay, so let's do a quick poll just to see where everyone on the call is. I think our Keystone partners are gonna post this poll. So does your hospital have a formal ED MOUD pathway already in place? Or you may call it MAT, or you may call it opioid agonist treatment or therapy. But basically, are you doing this already? Yes or no?
Nick, while everybody's doing that, I did post the note-taking workshop in the chat just so that folks can just have access to it.
Thank you.
Easily without having to go and search through email.
Okay. There's probably enough time for the poll. Can we release the results? Great. So about a third have a standing program and 2/3 don't, and that is okay. That's why you're kind of enrolled with our program in the grant. And we're going to talk about how to get some more of these no's into the yes column. Now, I want to take a second and just hear from some of the participants today about where people may be at and where their sticking points may be. I had reached out to the team at Henry Ford in Jackson. Is Dr. Lazar or Courtney McIntosh or Paige on and can you just quickly give us a summary about some sticking points they have right now and how things are going?
Hey, Nick,
Hey,
I'm here. Can you guys hear me okay?
yeah, it's good.
All right, I'm working clinically, so sorry if I have to jump away, but so I have a great partner. Courtney McIntosh has been helping tremendously. We're dividing it as like ED versus outpatient. Courtney works with the mental health aspects, and she can speak to her full role. But on our end, I spoke at our department meeting twice, gave the CA Bridge resources, did like an educational lecture, answered some questions, and encourage everybody to get their X-waiver. So we got a bunch of people in the pipeline to get their X-waivers. We have about 20 docs. I think we already have 7, and like another 10 are just pending. So that's good. We're a small group, so we're able to like go pretty quickly, at least at our site. I put up a bunch of, let me see if I can show you, flip it around. I made a buprenorphine corner in the fishbowl with a bunch of CA Bridge resources. So it's like a self-start guide, like the COWS scale and all that stuff. So people can just go to that corner. If somebody's having precipitated withdrawal, they can just pull the guide sheet, which those are amazing. So thank you, Sarah. Why reinvent the wheel? They're fantastic. The only thing that we're really struggling with right now is we're trying to get our PCPs on board. We have a list of like maybe 5 providers, and I prescribed my first buprenorphine script like 2 weeks ago and had a like kind of immediate halo from next morning from the outpatient mental health provider. And she's like, hey, can you just give me a call? And we had a nice like hour-long conversation about this process. And she hadn't really heard much about it yet. And so I was able to kind of grassroots update her. And she's like, if you could just hail me next time, I only have so much availability. I got 1 day a week I can do this. Here's my barriers. And I'm like, well, you've been doing this for a long time, prescribing buprenorphine. So I would love to have you at our next meeting. So it's organically happening. We're getting the right providers together. But we're trying to rope in the Center for Family Health, which is our kind of catch-all PCP organization for Jackson. And I got a phone call with their director coming up when she gets back from vacation. So yeah, it's moving fast, and it's a lot of work, but a lot of the tools are already there. You just have to get people to say, yes, I'll see this person in clinic. And I think that we have some barriers with providers in the outpatient setting thinking we're just exchanging one drug for another. They think that they're going to have a deluge of patients. So we're pulling data to say, hey, from the ED, we had 200 opioid overdoses in the last year present or something like that to our ED. Maybe it's more like 300, I don't know. But if we get a percentage of those that want to go to your clinic, that's certainly not 3,000, right? That's some percentage of 300. Mm-hmm. So can you guys handle some of those? And then the financial aspects you guys talked about doing the induction with the procedure note. I helped create like a procedure note for our department. I don't know if it will work, but I just made one, said, this is the COWS scale. This is what it is now. We did the counseling. So that would be helpful to know like how much that reimburses for. Cause I think, dollars sometimes speak to people.
Yeah.
Not particular our ED providers in that sense, but we like to get paid for what we do. And
sure.
If there was a template for the procedure, that would be cool too. I don't know if you guys have one.
I'm sure Sarah can drop that in. I think there is, but thank you very much for sharing your progress. I think you've highlighted some barriers that we'll review further.
One other point, I disseminated like all of your stuff to our PCPs and our ED providers, so including the video. So everybody has a lot of nice, wonderful things to say about you guys. So thank you.
Oh, wonderful. Thanks for that. All right. Well, hope you can listen in, but have a good shift otherwise. Okay. So for many, and I think myself included, it may seem that starting and giving buprenorphine to people in the emergency department and developing an ED MOUD program can just be an episode of red tape after red tape, and it can be frustrating. And that's certainly the case. I think what we hope to do today is highlight some of the common problems that people run into, and then show you how it's easy to overcome them. Because in the end, it's actually not that hard. The first barrier that many will come up against is the X-waiver. And the X-waiver was required back in 2002 when buprenorphine was allowed to be prescribed from the office setting in the emergency department as well. And it, made physicians and APPs do training for either 8 or 24 hours. And so, there was an extra step. And whenever there's an extra step, it's hard for people to get on board. And so luckily this is gone. I think the X-waiver did a lot of accessory damage, and that it's like an extra thing that makes buprenorphine and MOUD seem dangerous or weird, that you should have some specialized training for it or a specialized degree. And that's, of course, those things aren't true, but that's kind of the result of this X-waiver. But the training component's done. You still have to file the notice of intent with the DEA. So there is that minor step of filling in paperwork, but this is a 10-minute activity now and not a day's worth. So it's better, but I still think there's some residual barrier from the existence of the X-waiver at all. The second barrier is just educational, and that I readily admit whenever we do educational sessions about the pharmacokinetics, buprenorphine is a weird drug. We are used to going low on dosage and slowly titrating up. And the truth with buprenorphine is if you go too low, it's actually more dangerous than starting out too high. The phenomenon of precipitated withdrawal is unique to buprenorphine. And then, there's typically naloxone as a component to the medication, and that confuses people. It's sublingual, it doesn't get absorbed orally. So it is weird. And that makes it difficult when you're already dealing with these other barriers that we'll discuss. Not only is it weird, but it's new to us, right? This usually was in the realm of primary care, addiction medicine, psychiatry, and really only in the past 7 years with the D'Onofrio study in 2015 has it become apparent that we can do a lot of good by having these programs directly in the emergency department. Your partners in the hospital may also have difficulty either with the knowledge background, the regulations, and some of the stigma associated with ED MOUD. So pharmacists and pharmacies, so my experience was they didn't understand when I prescribed or I ordered buprenorphine in the emergency department that even if I didn't have an X-waiver, I could still give buprenorphine under the 3-day rule, which allows emergency clinicians to give buprenorphine in the ED setting for 72 hours, even if you don't have an X-waiver, as long as the patient comes back. As an inpatient, that buprenorphine can be continued indefinitely as long as they're an inpatient, as long as the primary reason they aren't admitted is their opioid use disorder. So if they're there for sepsis, endocarditis, then they can continue buprenorphine. And sometimes the pharmacists just aren't aware of this. That's in the hospital. Outside of the hospital, pharmacists may refuse to fill buprenorphine. There's a variety of complications and barriers that they'll set up that makes it a little bit challenging. So knowing which pharmacy will be your ally and not a barrier for you is important. Surgeons and anesthesiologists may be worried about acute pain control after you started MOUD, even if their guidelines suggest that we should be starting it as a new start and continuing it if they're already on it. So it's just kind of an educational component that we will probably have to take on if you're a clinical champion. And then the hospitalists may not want their newly admitted patients started on medications because of their unfamiliarity or their lack of desire to prescribe after they're discharged from the hospital. And so there's, the ED that you have to tackle, and then there's also the barriers of, your accessory services that can make it a challenge for you, even if you have your own group in order. And then really the barrier that underlies most of these items is stigma. I think what we've heard time and time again, both within our programs and helping others stand theirs up, is, as Alan alluded to, if people hear we have an MOUD program, more of those patients will come. Or when I did my X-waiver training, it was the 8-hour session. It was mixed with primary care physicians, and their questions were, do you have a special afternoon or a special day in which you have those patients come, right? So it's as if they're, less than the rest of your patients. You don't want them mingling with the rest of your patient cohort. And that's just rooted in stigma. I think what I realized after starting doing medications for opioid use disorder is that the reason I think I and many had avoided these encounters is because I felt like a poor clinician when I had encounters with those with opioid use disorder, because they were never satisfied and I was never satisfied. They were either continuing to have pain, they were continuing to be in withdrawal despite my best efforts. They often would return with repeat overdoses. And so kind of your reflex is to not like the patient because they made me feel bad about myself. And now that's not the case. I feel like now these interactions go very well, and they're a highlight for me, and I seek them out. And that just wasn't the case before. Again, as Alan alluded to, the most common thing we hear is, why would I help people just trade one addiction for another? This is from patients, it's from clinicians, it's from family members or their guests. And remember, being on medications for your opioid use disorder is not trading one addiction for another. You are trading in your opioid use disorder with all of its consequences for a chemical dependency. And that is an okay thing to help people to move towards. The third item that we'll hear frequently is, I shouldn't be offering medications to patients. When they hit rock bottom by themselves, they will know and seek treatment. As if we can't facilitate people moving in the right direction, and they have to be doing it themselves. An offshoot of this is, it's a disorder that they're doing to themselves. I think if you're of that mind frame that patients are responsible for all of their own problems, this probably isn't the right presentation to have that debate. But even granted that's the case, that's kind of our bread and butter. We take care of accidents, right? And I think the person that cuts the avocado in their hand, that may be a silly thing to do, but we don't make them live with the gash, right? It doesn't have to heal by secondary intention. We'll wash it out and clean it up and sew it up, even though, that may have been a mistake that they made. So I think tackling stigma is sometimes the most challenging thing to do, but it is one of the biggest barriers we encounter. A legitimate concern that almost everyone will experience is lack of follow-up, or how to get patients there. Even if you have follow-up established, maybe they don't have a ride, they don't have a phone. And so setting up a system of transportation, of communication, having peer navigators, peer recovery coaches, social workers, case managers, and reliable outpatient follow-up that will continue long-term medications is very important, but can be a barrier initially. So I've set up kind of a maze of red tape and regulations that it may seem daunting to try to tackle, but ultimately that's why we're here. That's why you've enrolled in the grant. I think we're comfortable helping you through every step of the process. Please reach out either at the website or by email. I'll put my email address in the chat as well. But now I'm going to turn it over to Dr. King, and he can start drilling down into ways to get your program started.
All right. I cannot start sharing while the other participant is sharing. Oh, gotta take turns. All right. Thanks, Nick. Appreciate it. How to start a program. Oh, this is the fun part, I think. So you got to ask your question. We'll start with the polling question. Looks like, what component is necessary before having your ED MOUD pathway go live? Are you stuck on buprenorphine in the ED, 50% X-waivers, and are excited about prescribing buprenorphine products, approval from anesthesiology and trauma surgery, follow-up clinic with providers willing and able to accept your patients for long-term MOUD? So just something to think about there. So overview of this part is we're going to talk about identifying a champion, how to get buprenorphine in the ED, X-waivering your providers, engaging an outpatient provider that you can work with, and then creating and disseminating a protocol. So this can look really complicated, and it can look like there is a whole lot of stuff to do. And yeah, honestly, there is a number of things that you got to do, you know, but the whole idea is you got to remember is you got to get someone from your emergency department to outpatient service or whatever that you're working with, right? From the ED to an MOUD provider. It seems pretty simple. And there's lots of different things that you can think about. Do you already have an inpatient service available that you can, you know, ask or pick their brain or get ideas of what are good outpatient providers? Are they interested in helping out or expanding their care? Because sometimes, honestly, you know, a lot of outpatient addiction providers don't think about the emergency department very much. It's just not on their radar. And it's really interesting when you talk about, you know, how important emergency department is for identifying and referring patients. They get it, but it's just not on their radar. It's really interesting. Pharmacy, like Nick talked about, you got to make sure that it's there, it's accessible. It doesn't have to come from another part of the hospital, that it's in their, you know, Pyxis or whatever medication dispensing machine is. Do you have a protocol? Always, you know, pharmacists are some of my favorite people, and they're really helpful about protocol creation and coming up with evidence and getting it through whatever committees need to happen in your hospitals. Information technology, are you going to set up a screening question? You know, I think there's some discussion that we can have with regards to that, if it's necessary or not. You know, what kind of prescriptions need to happen? Do you auto-populate something that's already there in one of your boxes? You know, we use Cerner, and so we made a easy to click on prescription that's just on the home page, and so it's always there and people can find it under the common orders that we do. Are you tracking these things? And then in terms of you know, intervening and referring, you know, really you just need clinicians. But if you are fortunate enough to have recovery coaches or substance use navigators or social workers or community health workers in your ED, you know, they can also help a lot and take the burden off of the clinicians themselves, but it's not necessary, right? And then transportation, like, does your patient population need it? Who's going to provide it? There are some local groups that could, insurance can do it. Get cab vouchers. Different hospitals have different ways of getting people from one place to another. And then, you know, it all talks about, like, are they available 24/7? And then finally, and most importantly, when you're identifying your MOUD provider, you know, first of all, figuring out who they are, what kind of services do they provide? Are they interested? Are they available? Do they have a certain time that they're going to do it? Where are they? Are they hard to get to? Are they easy to get to? And then what do they think about sharing information? Like, is there a communication that you can have back and forth? Of course, you know, being paying attention to HIPAA and all that kind of stuff. You can make these MOUs where you can actually share information. At least it's not the patient specific, or you can have patients sign saying, like, yeah, it's cool if you guys talk about me, so you can create the best handoff possible. And then are there telehealth options out there for you? And so, you know, at the end of the day, not all of these things are required. And Ariana is going to talk a little bit about, you know, really making your program A+. But, you know, at the end of the day, it is very basic, getting someone from the ED, starting on the medication if they can, and then getting them to a hot or warm handoff like an MOUD provider as soon as possible, because the longer you wait, the longer the time is between them coming to the ED and getting in front of a provider, the more patients you're going to lose, right? So let's talk about the champion, right? If you are on this phone call, there's a good chance that you're a champion. And there's been some academic papers that look at what are the characteristics that can influence change, right? How do you implement something that's new? How do you bring people along with you on this newish thing that's going to be happening in your hospital? And so the, you know, champion characteristics could be, they could be influential, they have grit, kind of like Rocky Balboa, they just keep bouncing back up, even though they get told no. It's like, okay, well, let's try this again. They take ownership of the problem, they can be persuasive. I think very importantly too, that they have to be physically present at the point of change. So you got to be working there. And it's really hard for someone who's, and no offense, but if you're an administrator that's multiple levels up, that you don't actually see patients anymore, or you're not in it in the ED or at that point of change, it's hard to know, all of the ins and outs of this new thing that you're going to be doing. And then you want to bring people in, right? You want people to participate, and you're not trying to pull people along or mandate things. So it doesn't have to be just one person. You don't have to have all of these characteristics in just one single person. You can break this down. You can have a core group of 2 or 3 or 4 that work well together, and that might subspecialize in message creation and then interacting with different parts of the hospital system, et cetera, et cetera. Buprenorphine in the emergency department. So this is, like one of the most important parts. It has to be there in the ED. Like I said, in any medication dispensing machine, it should be easy for your nursing staff or whoever is administering medications to go get it. It should just be right there. That there can't be a big time or delay in doing it. And we'll talk about a couple of reasons why, but you can't have people waiting around for hours while it's coming from central pharmacy to get into a patient. That's not feasible. And you're going to lose patients as they wait longer and longer. Nurse training on administration. Like I said, I failed my first buprenorphine administration because I didn't really anticipate that sublingual medications are not super duper common, and that and the nurses weren't really trained on it or familiar with buprenorphine when we first started. And then they had to be reminded, even though it looks like a tablet, it still goes underneath the tongue. And if you swallow it, you're not going to get any availability whatsoever effect of the medication. Having your pharmacists involved, right? They're going to be the ones that are going to be supplying and ordering and tracking buprenorphine. And so it's really important to have your pharmacists. And if you're lucky enough to have amazing ED pharmacists like we do, they can be so helpful and really make you successful. And then use an accepted protocol. I did this, and I'm guilty of this too, is I tried to make my own protocol, and it was a bad idea. It's really easy. There are so many of these protocols out there that are accepted that have been used thousands of times, hundreds of thousands of times out there. Just use one of those. And like we talked about before, that they're, California Bridge or Yale, or there's a number of different organizations out there that all you have to do is just do a quick internet search, find a buprenorphine initiation or start protocol, and you can just use that one. And most of them are readily available. They want you to use that stuff. There's no reason to, like I said, reinvent the wheel or have to make something just yourself, because first of all, the evidence is emerging a little bit. Some of the older protocols you might see, as Nick talked about, use these lower doses that are probably not as effective to try to get people from 0 to 60, as well as you need to, or as efficiently as possible. And so, starting with these higher dose protocols is probably the best thing for most of your patients. X-waiver your providers. Like, how do you get people to be comfortable using the medication? Like Nick said, it's new and it's scary, and there's like some, clunkiness to the medication that you have to pay attention to. And then there continues to be that stigma and that hesitancy of using these medications and these thoughts that just take a while to get out of your brain, that we're not trading one addiction for another. We're using chemical dependence, those properties, to treat a substance use disorder. And it can take a while, and you need to talk to the providers multiple times, but in order to get them excited or interested into it, there's lots of different ways, right? First of all, just, X-wavering is pretty easy. And there's lots of slides out there that we have that you can send on your listserv and say, just got to do this. Just follow the PowerPoint, and it'll tell you how you do it, what you type in. It takes a couple of minutes. There's some administrators could probably just do that for a lot of your clinicians anyway. You can talk about it at staff meetings. Like, if you get 5 or 10 minutes during your monthly or weekly staff meeting, you can have everyone say, like, if they're in a Zoom format, for example, like, can everybody just pull this website up right now, and let's just get this done, so we can just like say we're done with it, and everybody we know has submitted their X-waiver application. Boom, we're like 100%. We're awesome. How good are we? You can incentivize, right? There are reimbursed trainings that we offer for a lot of these sessions, is that, people can not only get the education about how to use the medication, but also can get reimbursed for their time, because it is a little bit of a time barrier for people to have to spend to feel comfortable enough to use the medication. You can also talk about, the RVUs that Ariana is going to go into a little bit, that starting people on this medication and a referral process does increase their RVUs, like by a significant amount. And then, is there something that you can talk about with your group that maybe we, incentivize them or do a little group bonus for having obtained their X-waiver within a certain period of time? Like, there's a lot of different ways to do it. And then finally, if people still don't feel comfortable with it or their X-waiver, but they just don't use their waiver very often, you can ask them why gently, and then provide them with training resources like links to these training sessions that we have. There's a lot of those out there. So let's talk about engaging your outpatient providers. This is actually a lot of fun, and I don't know why it is the most fun for me, but you really get to get out there in community, like talk to people, bridge some gaps, understand that we're all fighting the same fight. We're all on the same team here. And it's really nice to unsilo yourself and make these connections and just be like, oh, wow, there's a lot of really great, cool people out there that are trying to do the same thing that we are. Why haven't we done this a long time ago? And it always just, it blows my mind about, how many resources and people out there that want to help you out just didn't know that you existed or that there was interest out there. And so when you're looking at your providers, or referral process, like who is referring? Is it the clinician? Is it the social worker? Is it the substance use navigator like we talked about? How do you do it? Is it a phone call? Do you have are the carrier pigeons? Does anybody have those anymore? I don't think. How is this happening? How do you get somebody engaged into that clinic? When does it happen? Is this just like a 9 to 5-er? Is this a 24/7? Does someone carry a pager? Do you send an email? There's lots of different ways to do it. And then where do they go and when? Is it a certain day of the week or a couple of days of the week? Is it morning walk-ins? Can it be anytime? And all of this really just depends on the outpatient providers and your microenvironment or the COSM that is around your hospital system. Some discussions, like when you're having these discussions, and they're really interesting to get different people's perspectives on what their prerequisites are or what their understanding of like what we do in the emergency medicine realm is. And so it's very eye-opening, and you can have these great back and forth dialogues so people can understand where you're coming from and where they're coming from. So they might have some prerequisites like, no, you have to get them on a medication. So however that occurs, please get the start done before you send them to us. Hopefully that's not the case, but it might be the case. And then, there's always like a back and forth. Like if you don't feel comfortable doing it, then we can do it in the hospital and then send them right back or whatever the case is. The idea is that you're really trying to engage as many people as possible. You have to have like, I think, an open and upfront discussion with your outpatient providers that there are going to be no shows. And there's going to be like a decent, probably for a batting average and a baseball player is going to be pretty good. But for, what we would like to see, it might not be, as high as we'd like to see. So it might be between 20 and 90%, depending on how it is. And then you can start asking the people who didn't show up, if you're able to follow them some way, like what was the barrier? Like what happened there? Was it the timing? Was it hard to get to? What happened? And then you can, or if there are going to be miscommunications, right? Between your provider group and then the outpatient provider. So just, understand it and have an open and back and forth, honest dialogue, respectful with them, that, there's going to be some goofy things that are going to happen, but we can work through these things. And, we're here to support each other, but more importantly, support the patients. And that gets into the feedback component too. Can you, there's a lot of QA in that I do for the charts of the people in my group. Like, are they using the GT2213 code and getting their RVUs? Are they documenting that if a patient comes in after an overdose, that they actually had a discussion about referral afterwards? Did they prescribe the medication so they could do a home self-start? Or if there was a complete refusal of that, at least document that to show me that you're having these conversations with the patients. And then when patients do go to the MOUD providers, like they can also talk to you via, whatever mechanism it is, like, how is this going? Like, how are the patients doing when they get there? Did they appreciate the service that they received in the emergency department? Because that can actually be a very big motivator for your clinicians to continue doing that positive change for themselves, right? So if you tell somebody like, hey, you did a start in the ED, they went to our partner clinic and they've been there for the past 2 weeks and doing really well. You tell the clinician that did that start, even though they may have had like maybe not the best interaction with the patient because they were in withdrawal or like, whatever the deal was, you tell them that they're doing really well and they appreciate the care that they received in the ED, that's going to make that clinician continue to do that. And so having real easy feedback mechanism way that you can continue to tell your providers like how they're doing, how their patients are doing, makes them feel much better about what they're doing. And so they're not just sending their patients into the abyss. They know that what they did was the right thing and the patients are doing better because of the intervention and the change and the different style practice that they have made. So the protocol, like I said, don't do what I did. Just listen, there's a lot of great ones out there. I put the California Bridge one up here. They're easy to follow. It just takes like a minute or two to just read through these things, and they're pretty simple. Yeah, at the end of the day, it's just like know what the contraindications are. If you have uncomplicated opioid withdrawal and they have a CAWS of 8 plus, an abnormal vital sign or something that you can find on examination, just give your medication. You can give 8 to 16. And like I talked about, if you look at evolution of these protocols throughout time, you'll see that the doses have changed. And I think the best evidence now and the best effect is giving the higher doses up front so you get the patients feeling better and minimize the chance of having a precipitated withdrawal. But at the end of the day, there's no reason to try to make your own. Just don't do it. It's annoying to make, PowerPoint arrows going all over the place. And like, it's already been done for you. It's beautiful. It's there. Like, why not use it? And then, again, screening, it depends on a lot of things. I think that's something that we could talk about offline if you think screening is a good idea. But one thing I just say is like, don't get caught up on the screening before you implement anything. Like you don't have to screen. You're going to find these patients just by taking care of them. There's no reason to have to put a screening thing in there or any barriers for you to implement ASAP, right? Really, the only things that you need are emergency department or center or whatever you call your place where you take care of patients that are coming into you, and an outpatient provider and a way to get them there. Like that's a very bare bones thing what you need to do. So don't make it too fancy before you actually implement. What the intervention is going to be, follow up, and again, don't reinvent the wheel. I think it really helps a lot when you are doing these things to anticipate how things can go sideways. And if you do, and they happen, and you've talked about these before, then it doesn't become such a stressful situation. And so the examples I have here are precipitated withdrawal. Like people are going to run into precipitated withdrawal and they have to know that it occurs. And when it does happen, like take a deep breath, you're going to be okay. Patient's going to be okay. How do we take care of this, right? There might be a lot of hooting and hollering and stuff, but they're going to be okay. And so you have to know that that's going to happen because it's probably going to get all of us at some point. So anticipate that one, because when you're using buprenorphine, it is going to happen. And especially the people who don't have the fundamental training, it might happen with a little bit of higher degree just because they get a little bit loosey-goosey with it. But be prepared for that. Pushback from nurses or other clinicians, right? Nick already talked about that a little bit, is that, some people are not going to feel comfortable with this medication or have their own stigma with it, but you can continue to have the right conversations, show them the benefit, show them examples of where it's gone very, very well. And then, find ways to help them out, right? Like I can start them on the medication. You just got to continue it, man, when they're inpatient. You know what? I'll put the order in for you. Oh, okay, great. And I think I found like a lot of providers are cool with just letting you put whatever order in because they're not comfortable with it. And while they're, inpatient, for example, they can, be taken care of from that standpoint. That's cool. And then nurses too. I haven't actually run into that a lot. Like most of my nurses have been amazing adopters of this, and they see like right away, because they're in front of the patients way more than I am, that the patients feel much better and they're much easier to deal with because they're immediately happy. Like they were kind of irritable and vomity and like uncomfortable. And then all of a sudden you gave them medications and they're like, what's up? High fives. Like who doesn't like high fives? Everybody likes it. And then you're trying to win everybody with like the why. Like, why are we doing this? Just continue to go back to, this is about the patient. This is about best evidence. It's not like that this is a brand new experimental thing. There are mountains and mountains of papers that you can just crush people's inboxes with about why this is the right thing to do. And, we're happy to give you gigabytes. How many papers do you think we have of like, benefit of this kind of practice? But, that's the kind of thing that you could do. And then just get, most people, when you are face to face with most people in the medical profession, they'll just like melt in your hand. They're fine. You got this. And then how are you going to set this up, right? Like, you have a champion on top. So it's always nice to have like a touch point for your champion or your champions that can continue to come to you with any issues, right? And so you're going to do a lot of learning. That's not like, we don't, Rome wasn't built in a day. You didn't ride a bike the first time you tried it. There's lots of different things. And so you continue to work this out until it becomes more and more of a smooth process. But it's always good to have, a single place for everyone to go to when asking about like any of the questions or issues that might arise. And then who do you want on your hospital team? Ariana's going to talk about building this out, but these are a lot of things that we talked about already. Having administration there can help out, but make sure that the champion or the champions really are the people that are there in the ED and providing care. And then the next steps, like when you're ready, like once you identify your provider and you've had these discussions about how this is going to go, make sure that you, with your team, have reviewed the implementation guide about how you're going to do it. Make sure that you're developing a timeline for getting each phase done if you want to be super fancy about it. And then make sure that you are assigning team members, whoever's there, with whatever action items need to occur with deadlines, so it doesn't just hang out there forever, right? Because the longer you wait, the less people you're treating. And then, the worst, you're missing people, and people are going to die. So now I'm going to stop sharing, and the best of the best is going to be here. My friend, Ariana, I think we should just do some sort of,
I know, like pass the baton.
yeah.
All right, let me share my screen. Okay, here we go. All right. So we're going to talk about tomorrow, but actually, listen to Alan. You're already starting some stuff for tomorrow today. So what I have to say about this is when I started the program, and actually Sarah's reminded me, I actually didn't start a program. I just started giving the right medication at the right time to the right patient back in 2017 with that first pregnant patient. And I had follow-up care. That was it. There was no navigation. There was no big system. I communicated with my group, like all my clinicians, what we were doing. I encouraged X-waivers, but we only had 4 when we started, and we had a clinic willing to accept patients. At 1 year's time, I actually received a call from a journalist who was asking about my program, because I actually didn't think this was special. So I do want to sort of instill that in everybody, that I didn't think this was special. It was actually a very easy program. It was very easy to initiate medication, because I was just giving the right medication to the right patient at the right time. And when I was asked to look back at my data, that's when I actually thought it was special, because I was kind of going along, giving medication. Others in my department were doing the same. And then I looked back because a journalist asked me, from the New York Times actually asked me to look at my data. She said, "Oh, how is it going?" Oh, I'm like, that's a very good question. So I looked back at my data, and I had this great follow-up rate. My follow-up rate was like in the 80 something percent. And actually more of my patients were still in treatment at 1 year than weren't. So that really opened up my eyes. And I treated more than 50 patients in the first year. We call that, Alan, I know you said everybody's afraid of everybody just showing up. We call that the zombie apocalypse. It just doesn't happen. And it just hasn't happened anywhere. And we are working now in 300 hospitals in California. We're working with Michigan and 40 states, and it just doesn't happen. And once you start doing this, you actually want the zombie apocalypse. Why? Because we make such a difference. Folks go from feeling like a zombie to feeling normal in less than an hour. So then you want to build a program. And that's where I'm at now, is after 1 year, when I was just kind of doing my thing and it was working, I built a program after that and became very passionate about building programs. Why? Because I was able to reach more people and do a better job. So how are we going to do this? So we want to build teams for sustainability. So again, we'll always give buprenorphine for opioid withdrawal now. Why? Because it totally works and it's easy and it's so much better than any alternative, and we save lives. Though we've built in things that we know will help sustain this treatment in the future, because you have enthusiastic people like me who give this, see it work, watch the pregnant patient just get better, deliver a healthy child, and keep her child and live a life where she has a home, a job, her children. And you think, oh my gosh, I gave a sublingual medication and it changed everything. Then you're going to have the people who are like the middle of the road, our middle adopters, who will say, okay, we're going to do this. I guess I've seen a few people do it. It works great. And now we are building our team to include the late adopters, the people who have literally told me I'm crazy. And those, there's just science to implementation. This happens all over the place. And what we do want is a shared understanding of what's going on so that every patient gets high quality, evidence-based care every time. And that's where we've landed, is it's become unacceptable to do the right thing, or to not do the right thing, excuse me. So the only thing we want is for folks to do the right thing for people. So how do we do this? We just want to normalize this, integrate this into the general medicine that we practice in our hospital. So I'm going to talk about how we've seen this work both in my hospital, which is a rural hospital, single system hospital, to entire systems of care, to entire, large hospital systems. What works to normalize this so everybody's on the same page and we meet the needs of the folks who need this treatment, right? So we want to normalize high quality care for people who use drugs. The first thing I did actually, and I utilized some grant funding to build this, and I surveyed folks at the end of it, I developed a substance use disorder committee. I'm going to talk a little bit more about that. Then what I would ask you to do is go on tour. We call this like the road show, go on tour, tell everybody what you're doing. Alan, I appreciate you've already gone on tour. That's great. Adopt some quality metrics. So how do we make sure we're standardizing high quality care in our hospitals? We have expectations for quality. We look at it. If things are falling out, if we're missing the mark, we try to determine why and we fix it. So putting this into the quality metric game is very, very important. You want to also look at equity. At some point, we're given the right medication at the right time, but are we missing groups of people? And I'll talk a little bit about things that you can do to incorporate equity in your program. And then ultimately, we all know there's some amazing people in our communities who are doing this really outstanding work. How can we bring those services into the patients who need it the most? And we know that those are the folks in our emergency departments. I know so many people, the people who need, for example, food, who have food instability, who need housing, they are not accessing those resources in the community. They're ending up in my emergency department for one reason or another, frequently actually dropped off there as a last resort. So how can we do a better job bringing the appropriate resources to the folks that need it the most? All right. So I'm going to start here with our substance use disorder committee. This is a group of great folks who we get together once a month and we discuss how to push for better care in our community. So I started out, this is a group of people. I have a navigator, but maybe you have a social worker who's very interested in this. So who do you want in this committee? So I incorporated the physician who is seeing our patients in follow-up. And actually on the screen, it's Lonnie J. Of course, I was the chair of the committee so I was the emergency department champion, but we actually made a hospital champion who was running the substance use disorder committee. So I'm the chair of that committee. And then we incorporated, again, our bridge clinics, some outpatient physicians. There's a couple of them here. The clinic manager, the person who's really helping manage the outpatient clinic we're sending folks to. And then we invite various entities to come. We have somebody who's looking out for vulnerable populations, people experiencing homelessness. So we have executive support. We have our vice president of our hospital who's in charge of population health, our chief medical officer, our nursing director, our emergency department nursing director. And then there's some other folks who've been interested. So we brought in the nursing director for OB. We've brought in a hospitalist and we've named champions. So we have a champion for surgery and trauma surgery. This is really relevant, actually. I have to put a plug in for that. we created, I have another champion in my emergency department, one of the docs, and then we brought in a pediatrician. Why would I bring in a pediatrician? We actually, as a rural hospital, do not have a NICU. So we found out that actually when moms deliver at our hospital who are on buprenorphine, they were being separated from their babies. Their babies were being transferred down to a different facility an hour away. And we knew that if we connected by telemedicine, our pediatricians with that facility, we could keep moms with their babies. Now we keep 75% of the babies who are being born to moms who are on buprenorphine or methadone. We keep them in our hospital through an Eat, Sleep, Console program. And we were able to engage our pediatricians and OB/GYNs to work together on that. So again, you can really drive better care for your patients by having a committee. We meet once a month. We talk about how to better care. We look at gaps in our hospital system and where we need to improve. We share wins, we share challenges, and we improve care for people who use drugs. And why would we do this? We've increased naloxone distribution. We've been able to reach our pharmacists and improve a sort of a shared understanding amongst folks. And we keep moms and babies together now just through this committee. So this can be very meaningful. A lot of folks who are doing a lot of this work have formed this committee, kind of along the lines of stroke committee, sepsis committee. And then we report out at our emergency services committee. We will go to other committee meetings and report out on what we're doing. So this is a great way to organize your efforts. And I have found we're much more effective in what we're doing when we have a group of people who are agreeing on something and then pushing things forward. And this also builds leaders. So I have an OB/GYN champion who started out thinking I was crazy and was a naysayer, and was able to then bring up all of the OB/GYNs to have this shared understanding. I have a pediatrician who's been doing great work and reaching out to schools. And so it doesn't have to just be passionate Ariana in this rural community. I have a whole group of us who are able to share what we're doing with folks in the community. So really what we're trying to do in the substance use disorder committee is build leaders. And now we're looking at it. There's more things that become unacceptable when you build these leaders. And now we're looking at how to improve care for people experiencing behavioral health or mental health emergencies. So we're really able to hone in on the things that will make a big difference by having the right leaders and building those leaders, giving them the opportunity to lead their own groups into, providing better care for people who use drugs. So we are now reporting to the benefits of this to our executive team. So we are able to show we can improve emergency department length of stay. We can decrease return visits, readmissions. We can reduce opioid equivalents. We started our program treating. We did do some opioid stewardship. A plug here, I have to tell you, opioid stewardship has been where a lot of people landed, and all we've seen is increased overdose deaths. People are cut off of opioids. If they turn to buying it on the street, pressed fentanyl is what's on the street. So to start an opioid stewardship program without treatment is leaving an enormous gap, where what is being filled in that gap right now is clandestine labs who are making fentanyl and profiting off of that. We need to fill that gap with medical treatment. So making sure we're pairing any opioid stewardship measures with our treatment measures. And then we're able to report to our executive team our patient follow-up rate. We've had a patient follow-up rate as high as 97% at some point. And with COVID, we kept it above 80%. So we look at this as a marker of how we're doing, how we're connecting to our outpatient folks, how we can better improve care. And if our follow-up rates go down, we try to dig into why. What's going on? Is the bus late? At one point we had decreased follow-up rates, and we realized that one of our clinics had a 5-minute waiting period. If somebody didn't show up within 5 minutes of their appointment, they were cut off. So we had to change that. So there's a lot of influence that you can have that will promote better care for your patients. And again, looking at these things, reporting it to your executive team monthly is very helpful. And then we also report on our naloxone distribution program. We have more than 30 people whose overdoses have been reversed with the naloxone we've distributed from our emergency department. These are important numbers. These were 25-year-olds who were dead. So this is important to report to your executive team to build that sustainability that I'm talking about. I have to say, after starting to report these things, we have a navigator who was initially grant funded, who is now written into our emergency department budget. That's a sign of success. We are now including that person as infrastructure in our emergency department because we've been able to prove how effective it's been. So I know Andy had mentioned I'm going to talk about billing mechanisms. So this is important. Billing revenue, this is the reality of, we don't have social medicine, right? This is a reality of medicine. We have to talk about how we pay for things. So billing for SBIRT in the emergency department. SBIRT is screening and brief intervention referral to treatment. So we actually have a hospital. I'm working on this right now. So billing for SBIRT. So our navigator can do a screening, brief intervention, referral to treatment and document it. There's different tools. We actually have some of this available. Sarah, I don't know if you find the right tool, but we can drop this in the chat. But there's ways to look at different billing mechanisms. And one of our hospitals in California is billing, I think, about $225 to $250 per screening, brief intervention. So each time our navigator sees somebody, and then the licensed clinical social worker is able to sign off on that note, they bill the insurance and they actually get paid about 35% of the time. So, you can do some math on that, and they're seeing about 8 to 10 people per day. So this is one mechanism of getting in there and billing for some of the services you're providing. So that's on the hospital side. That's the hospital can bill for that. But in terms of billing revenue for the clinicians, for me, when I'm doing this work, there's the G2213. So this is a Medicare code that was developed. And yes, some of my patients have Medicare, many of my patients have Medicaid. So the big thing here is to make sure Michigan Medicaid is covering this code. And it's literally something they just have to turn on. So it's making sure that, and certainly we can do this, there's policy levels we can do this at, but making sure that that's turned on. And I don't know, Nick or Andy, if if this is being reimbursed through Medicaid channels in Michigan, but that would be helpful to know. But I would start documenting this because many states are adopting this. It's pretty easy once Medicare establishes the code for Medicaid to adopt this. And this has been working. I had a physician tell me that intubation pays at a rate of like $85 or $90, and this pays at about $60. So not bad, especially if you have resources. And we have an example, a dot phrase that I know that we were putting in the chat. So I have a dot phrase that I use in my EMR. I put it in a few of the stars. I just put that my navigator saw them, that I provided or prescribed medication for opioid use disorder, and that I referred them to a clinic. It's really, really easy. It takes me literally 3 seconds to put in this code. And again, we are finding it's paying out in our state. So partnering with counties, with community health centers, with insurance. So in California, we actually, we've developed a HEDIS measure. So we've developed a HEDIS measure where they're looking at follow-up after. So insurances will be more prioritized if they have, if they meet these HEDIS measures. We're able to drive better care, and hospitals are more interested in this because they're trying to make sure that follow-up after for people who use drugs, that people have certain expectations, and so this will help put more resources into places. So again, there's various billing mechanisms. My hospital, we are also currently working the county to do ASAM assessments for them, because they have a 1 to 3 month wait for ASAM assessments. So again, we are actually working on doing the ASAM assessments when we can from the emergency department. And ASAM assessment is just a more detailed assessment of somebody. And that might be another way that we are able to decrease barriers for patients and bill for that. So, and then again, there is renewed state funding. There's state opioid response monies coming to each state, and there's also the opioid settlement dollars. So advocating for those to help fund your programs in your emergency departments. All right, so this is the part where you go on tour. This is not what it looks like when I go on tour, but I'm hoping it is for you. Really making sure you create that shared understanding in your hospital and your community. So I can tell you right now, today I'm on shift and at some point going to hop into the pharmacy meeting to make sure that I give them updates. We're going to actually every single department in my hospital and doing a perspective taking anti-stigma exercise. I've already gone to every department to tell them what I'm doing. So I literally will drop in on pre-existing meetings and do a 15-minute segment on what we're doing. And I thought, if I like one and done, right? If I do this, then everybody's gonna have a shared understanding. We're all gonna sing Kumbaya and treat people who use drugs with evidence-based care. That is not what happened. And though it did improve care, it's taken time. Think of other quality stuff you do in your emergency department, right? Did you just come up with how we treat people, with strokes and everything's perfect? No, any other medical issue that we're addressing, these are complex patients, everything's not clear, but we can drive better care by helping others see what we're doing. So really sharing what we're doing and then encouraging others to continue that treatment. So we now have almost all of our hospitalists who are giving buprenorphine inpatient. It starts becoming really silly when your hospital's not on board, because you might start somebody on buprenorphine in the emergency department. And if they're not giving the same medication, it looks awkward. And if they're also not willing to initiate that medication inpatient, it's awkward when a patient is discharged to go back to the emergency department to initiate care, right? So this is why it's really important to drive better care and create that shared understanding in your hospital. So go on tour, tell people what you're doing, and encourage them to make sure that they have a good understanding of how to do this. So slide decks, I'm sure we have lots of slide decks that we could share too. All right. Nurses drive care. Don't repeat my mistake. I unfortunately did not necessarily initially start with my nurses, and I really should have, because when I did a anti-stigma campaign, I did a 2-hour nursing intervention where we interviewed somebody with a lived history of substance use disorder, actually somebody who works in my department. And then we paired that with a neurobiology of addiction talk. We significantly increased our naloxone distribution and increased the amount of patients we were starting on buprenorphine. This is low-hanging fruit. Talk to your nurses. So you can create a wave. My nurses are all the time able to connect with patients and spend more time than I am. And so they'll identify patients and also make it safe for them to disclose that they're experiencing an opioid use disorder. So it just makes it a better program when all the nurses are on board. And I was afraid to share this with the nurses. I thought maybe it would be blocked. And the nurses have been some of my biggest advocates once I did the appropriate amount of education. So create that wave, get your nurses on board. All right. So we've talked a lot about barriers. Some of the things that I can tell you that was really helpful when I was addressing barriers is just signage. It's almost like when I put up a sign in my emergency department and made it official, because whereas people may have been tuning me out, hopefully you're not right now, when I put up a sign, it was like, oh, wait, what are we doing? Registration was asking, security was asking. And so it really created some interest in it. And it also helped us get rid of some stigma. So it's like, hey, no, this is the place we want people to come for treatment. So, I just talked about the perspective taking exercise. I can tell you that was very meaningful. And we, again, are presenting that to every department now. I talked about how we're teaching about the neurobiology of addiction. And when we paired those two together, perspective taking and neurobiology of addiction talk, and then we also talked about what we're doing. We're giving buprenorphine for opioid withdrawal. We're treating people who use drugs with kindness and respect. That changed everything overnight. And it was interesting because, you do evaluations. People were writing a page and a half about how this intervention changed their practice immediately, and they wish they would have had this information prior. So my mistake was taking too long to do this. I hope you don't make that same mistake, but definitely, talk about the barriers, talk to your nurses, and signage can help. This is what we talk about all the time. Addiction is a chronic, treatable disease, not a moral failing. This is where we start with. So we talk about this all the time and repeat it all the time because this is what's important to share. All right. And then, you certainly want to engage your teams. You want to make sure that all staff is involved. I already talked about how, registration was asking me questions about how security. There's certain groups of people that I initially, trying to figure out who I missed. So I also talk about language, and I have to say, one thing I did was just try to model appropriate language, not shame people. So, when we talk about modeling this, just by modeling this, having my navigator model this, having a couple of people that I did train who were interested and asked some questions. One way I knew that we were making a difference is I saw our diagnosis change from opioid abuse to opioid use disorder. It's interesting if you do an audit of your diagnoses from one year to another. So this is higher level stuff, but you might be able to see that you're changing language. You could do an audit of some charts. You can just look at some charts of where folks were diagnosed with opioid use disorder. You can look at the language used in there and see what kind of impact your program's having. But make sure you're providing that support to the emergency department team. Again, we do regular check-ins with our champion and our navigator. We do Wednesday morning meetings with my emergency department nursing director. And then our community foundation I speak with about once a year, and they report out to our community what we're doing. So we're building these trusting relationships with patients and families after discharge. The signage really helps, because the signage is not just for the person who's experiencing opioid use disorder. When the families of people who experience opioid related issues see the signage, know that it's safe for people to get care there, that makes a big difference. And then again, I talked a little bit, I'm going to talk about integrating quality. So we normalize this by making sure that we made quality measures. So we're looking at, we watch our follow-up after, we watch our buprenorphine administration rates for opioid use disorder. We're actually keeping a very keen eye on this inpatient. Our expectation is that folks, when they come, a very easy first quality measure is if somebody's coming in on buprenorphine, make sure they're being continued on buprenorphine inpatient. That sounds like low-hanging fruit. It's a great first quality measure to look at. So I'm doing on a national level, I'm looking at, within my staffing group, I'm looking at areas with the highest opioid use disorder, opioid overdose rates. So we look at the diagnostic codes for opioid overdose rates, and then what's the buprenorphine prescribing or administration rate. And if there's a big disparity between opioid overdoses or overdoses in general and buprenorphine administration or prescribing, there's a problem there. So it's pretty easy to identify places that may need a higher level of service or education. But again, just integrating this into the quality measures we look at, like other medical problems, can be very helpful. There are some quality frameworks that you can look at. There's Liz Samuels came up with this quality framework that actually with a bunch of folks from ASAP. I encourage you to take a look at this. There's some food for thought there. That's sort of just a general framework there that can be very helpful. I use this as, we're developing quality, integrating that into my substance use disorder committee, making it a quality improvement committee. And we are using this actually to help drive that. There's also an IMAT tool, and we also use this because when you form a quality committee, they want to say, see, what else is being used? What will we utilize to make this, objective? What quality measures? Sarah's going to share this IMAT tool. It's not a validated tool. We actually used it at California Bridge when we had sites do just a self-evaluation of how things were going at their site. And it really does provide some things to think about. So, you might look at something. I know that when I looked at the IMAT tool, I realized there's a couple of areas that we just forgot, that we just weren't addressing. So it was really helpful to look through this and figure out where we were and what gaps we needed to fill. So again, that is one tool. In California, there's also there was an award. It's called Cal Compare, and they had an opioid, an opioid award, and we used some of those metrics to evaluate how we were doing as well. So again, we were just out there really looking for something that was more. It was just a little more standardized, but again, this is not a validated tool. It's just something that can be helpful and that you can take a look at it. And if you would like to validate the tool, let me know. There's some, this was not a California Bridge. I think this was a few various people who are very into this work who came up with this because there's so many frameworks that were out there that were not emergency department facing, and this was an emergency department facing tool. All right, and so at some point you have to address equity. Who are we missing? So now, I have this great program. We have a substance use disorder committee. We're looking at quality metrics. We've engaged our nurses. We're taking on stigma. We're changing language. We have high follow-up rates. But what about equity? Who are we missing? So this is very important because in my community, we were missing our tribal population, our native population. And so we had to do a lot of outreach. We actually have a tribal medicine clinic, and we had to do a lot of outreach to them to figure out how we can improve care, improve access, and be able to actually a lot of our patients who, who were seeking services at the tribal clinic didn't really know about the program. So how can we build this and do this in a way that's respectful of culture and be, and how can we also, another community for me, another group of people we were missing were our Latinx population. And so we had to do some things to advocate for change here. One more area we looked at where we were seeing a lot of overdoses in my community were with our people who were experiencing homelessness. And then for my community in general, because we're rural, is our patients who are pregnant really had a lot of decreased access to care. So how can you look at this? I was trying to look for, I know in California, we have an overdose data tool. We actually have this in Michigan as well. One thing that you can take a look at, and this is something that, this is how I figured out that our, our American Indian population in my county was, didn't have the same access, as we were able to look and see who was overdosing and who are we missing. And we thought we had this really great program, and we have great follow-up rates. Yeah, except for we were missing entire groups of people. And so then we came up with action plans in terms of how we can embed equity in our program, how we can reach certain populations of people and do this in a better way than we were doing. So we did some translation services. We found groups that were providing better care for certain groups, and we were able to make some connections, and we're still working on this as we speak. But we also have people who are very, very remote, who we put a clinic once a week out in a very remote area where there's high overdoses. So just keeping an eye on what's going on in your county and your area can be very meaningful. So you can, because, I always say, what about all those people that overdosed and died? We missed them. They never came to our emergency department. This is important to look at because we don't want to miss these folks. So we want to make sure we see where the overdoses are happening. We've now developed a tool. We're actually worked with our county to develop OD maps so we can get real-time data on who's overdosing in our community, so we make sure we do the right thing. We look at housing instability. I talk to patients who are like, yeah, that sounds great, but I don't have a place to stay. I don't have food. So yes, we have to meet people's needs in order to engage them in treatment. So my navigator has helped with this, but we reached out to some organizations. You don't have to do this yourself. You can see what organizations are there in your community and make sure that you have a really, an open line to communication with them so you can advocate for your patients. I just had to, these are my kids. I had to put a picture of them in here because, you have to address the youth response. I have 4 teenagers. So we have gone out and talked to schools and teachers. It was amazing how many teachers think abstinence treatment is the way to go and that people who use drugs are bad people. When I went and just spoke with the teachers, they started using my slides and playing my videos in their classes. They've changed the perception of substance use disorders amongst kids. And just from 1 hour-long session I did at a teacher's meeting, it created this huge change. My kids saw the videos that we put together in their classes and they were super embarrassed. As you can see that I've got some characters on my hand, but we also engaged in youth opioid response. Did you know that a lot of people first use drugs around age 12? So by definition, addiction is a pediatric disease. Substance use disorder onset usually around 18, average age. First age of treatment is typically 28. There is a 10-year gap. That is unacceptable. So address the youth response in your county. You will save lives. You will save families. I like young people in recovery. If you're looking for some youth-related education groups, Young People in Recovery is a great organization, and I recommend reaching out to them. And then again, community involvement. So I'll wrap it up with how important it is to reach out to your community. So a patient's journey is so many different touch points in a community. Maybe they've gone to a detox facility. Maybe they went to a community clinic. They went to, now they're out of county patient. They have network issues. They ended up in, justice involved. They run they're from my jail facility. They will be discontinued on Bupe frequently, and then they don't have any treatment. We try to re-engage them in treatment. We want to make sure that every touch point in pre-visit to emergency department, there's a shared understanding that the emergency department we're always the safety net, that we are happy to engage in treatment. My medical director, who initially was a little bit of a, he was doubting this. He has said, reach out to the jails. We don't want anybody we've had overdose deaths from folks being released from jail without buprenorphine. Please drop them off on our doorstep. We would love to treat them. Those are easy starts for people being released from jail. So you just want to make sure you look at the patient's journey, figure out where the barriers are, and advocate for treatment at every step of the way. And then don't forget EMS. Leave behind naloxone, EMS education. Some of our EMS in Oakland, they are giving buprenorphine in the field, and it's working. I think it's like half the patients are following up. So that's huge. But even if you just started with leave behind naloxone, let EMS know what you're doing, create that shared understanding. We really want to make it so there's no wrong door, right? We talked about this in the very last presentation. Once you get to the place where you're giving buprenorphine and it's working, you want that shared understanding. And you might think, wow, this is a lot of work. But in the end, it actually makes it easier for you because people know that I will treat them with buprenorphine. They come in withdrawal. They know exactly what they need. I give it to them. They're engaged in treatment. And I look like a hero for doing the easiest thing by giving a sublingual medication. And I'm telling you, it changes the makeup of your community. There is all sorts of, it's the butterfly effect. People get their families back, they get jobs, they get housing, and all of these things that you looked at, you improve in your community by creating that no wrong door approach. So again, update the standard of care in your hospital and your community. All right, thank you. I will stop sharing.
There was a couple of questions that came up, Ariana, while you were talking specifically. I think, wanting to know a little bit more about the naloxone. How are you getting data? How are you understanding where that's going and what that's doing in your community?
Yeah, so we've made a very low barrier naloxone distribution project. So we don't require like box numbers or anything like that. We literally know because people bring in the boxes and we can tell that they're Marshall. They're from my hospital because we put a special sticker on them. We sticker them up with access to care. So they have stickers on them about suicide hotline. We have a sticker with our navigator on there. So we will have people come in with the box and it has our sticker on it. And in the last year, we've had at least 30 with our sticker on it. I just received a text, gosh, this is probably 6 months ago, but it was a Saturday and one of the docs who I work with just took a picture of it and said, hey, we just saved a 22-year-old with one of these. Where can I get more? And we had actually given out so much that we had run out and somebody ran back. We have a lockbox and somebody ran back and restocked our cabinet. So we know when we take the boxes out, we will report if there was a reversal with one of our boxes, and that's how we keep track.
And regarding the youth substance use, do you know exactly where you got the insight on age 12 being the first onset of drug use?
Yeah, I
if
can
you don't
provide
know,
that.
we can maybe, we can look at that and send it later.
Yeah, we have a whole pediatric, I have a whole adolescent talk, and maybe that's a good talk that we can actually do in the future, because we're going to do some more sessions, and actually talking about adolescence is really important, especially given fentanyl overdoses. A lot of youth are using fentanyl right now because it's cheap, it's easy to get, and it's easy for them to hide. So that might be very worthwhile to address. Again, knowing that big gap between ages of onset of a use disorder and treatment, and many people reporting their first use at a very young age. Sure. All right, any other questions? Maybe Andy, Nick, I don't know if you saw any. I really appreciate hearing from Alan that your story, that's where it's at, is you do those first steps. It's amazing how you build it, because I know I talked about a lot of things that you can do that I'm doing now in my hospital. It's really fun, actually. It's really fun to look at a system, and I'm telling you, there's so many things that we do in medicine. This is really rewarding because you can make a change in your entire community just by doing, it's like shifting thinking from thinking this is somebody else's job to saying, oh, I'm going to own this because this is an overdose epidemic. This is my jam. I'm going to do this. And man, you can make a difference in your community. So I just appreciate everybody on this call today, because you're going to save lives. When we look at communities where these programs start, you will save lives in your community by starting this today. For those, I think it was how many, Nick, was it 35% who said they're doing this right now?
Yep, I think 36, but
36%. So yeah.
Awesome. Well, I've been very motivated after hearing Ariana speak. There's comments that we should do this peds and OB-GYN. I think what we should do. So in September, I think we're doing one, and part of like 45 minutes will be about disparities. So we're going to talk about race-based disparities, urban versus rural disparities. I think that the prison cohort has been a victim of disparities, and I think we could probably throw in peds and OB-GYN. Maybe it's getting too much, but I think those are groups that are kind of neglected on top of the neglect we give to this patient cohort in general. And so maybe we can do a couple slides on those to have everyone be satisfied. Alan asked about some of the outpatient providers that I've interacted with only want to do 8 to 24 milligram dosing.
Yeah.
Alan, I have, we published a study. So some folks from California Bridge did publish a study on the big dose. And I actually have a couple of slides. I can share those real quick. Do you want me to share those slides real quick on big dose?
That would be wonderful. And like, I know that there are people trying to get opioid use disorder patients on like 32 milligrams up front. And like, there's this idea that we can get people loaded and they can be safe for a couple days. It's more so like when the patients are in the outpatient realm, the psychiatrists or other providers are like, well, I've only ever done 24 milligrams and 32 is way too much. Or the provider says like, your sheet says to give them 16 milligrams, maybe twice a day for the first day or two. And they're like, well, 16 milligrams is way too much. And I'm like, this is my first script. These are the resources I have. And I said, well, how's the patient doing? She's like, he's doing great. I'm like, okay, well, great. I'm glad he's doing great.
So I don't remember the paper off the top of my head, but there is a paper that shows, what is it? Any more than 24 milligrams has not shown benefit for overdose death, I believe, in follow-up.
Mhm.
And the issue is there is that paper that shows that there's no benefit after 24 milligrams, which is why many folks in the outpatient world don't do it. Because what the risk is the patient takes 24, you're prescribing 32, and they're diverting 8. So they're treating themselves, plus they're diverting a little bit.
Yeah, the problem is those studies have been are a long time ago prior to fentanyl.
Yep.
Right?
So I think there's the newer data is showing that, but that's why that is there, is because for a long time, that was the data that you could do it. It wouldn't cause any harm except for possible diversion. And diversion is a whole another topic that probably isn't a huge deal. Like people shouldn't do it, but it's not causing harm to the community, which is why we worry about diversion from other opioids. But that's why that is there. It's just, that's been the longstanding practice.
Thank you for explaining that, because now I have some discussion points to bring back to them and say, like, these people are on the cutting edge of doing this and have a lot of experience as well. And so I just step into the room as the new guy and going like, well, these are the resources I have. And like, this is your 10 years of experience. Well, like everything in medicine, things change. Like over 10 years, things are going to change a lot. Like we don't, put patients on backboards every time they show them for a car accident, but we did that as dogma for years.
Yeah, kyphotic 90-year-olds. Yeah.
But honestly,
the follow-up to that though is what we're talking about here is in the acute setting, right? I know that a lot of the conversations that we've had are amongst all the hospitals and our clinical team at California Bridge is really addressing that specific question, really with the concept, like we're treating the acute moment in the emergency department. As they move forward in their treatment, that dose will likely go down. That will change and evolve depending on the treatment, right? So isn't that a relevant part of that discussion and maybe something that those folks can buy into that concept?
Sure. Yeah. And you want to pick your battles too, Alan. Like, hey, if you have to put that battle off to later, that's totally reasonable. But yeah, and we're just giving the right dose in the emergency department. So this is for induction in the emergency department. But you can see there was, if you look at the one 16 milligrams and above, there's probably 360 patients who were started above 16 milligrams with no adverse event. And this is the other one is when you do load buprenorphine in the emergency department, it just lasts longer. So it's really safe, lasts longer, which is why we sometimes load with higher doses in the emergency department. And if you wanted to any of these resources, I do, you can certainly look at that JAMA publication on the big dose too.